over a little bit quicker, and we can kind of slow down where we need to. Let's see. Start recording. Okay. There we go. Okay, so continuing on pericardial disease. So one of the big things that we talked about yesterday that we're going to need to do. So the big ones are really tamponade. That's our emergent concerning one. We alluded to constriction. We'll talk more about that today. And then what we need to do is differentiate between constriction and restriction. That's going to be an important factor as well. So there's one slide that goes in particular the differences and the differentiating factors between those two types of pathologies. So pericardial constriction is not common, or it is uncommon. Okay, so you might see it once in a while. It's not going to be something you see like on a weekly basis. Things like mitral valve disease, aortic valve disease, you're going to see those every day. You're going to see PFOs and stuff like that every once in a while. Things like that are, common and somewhat common. These things are uncommon. So pericardial constriction can be relatively vague in its signs and symptom presentation. So it really can go undiagnosed for many years. Remember that unless it's pericarditis, that is an acute process, whereas most of this pericardial constriction develops gradually over time, very chronically, and therefore the signs and symptoms are less evident and less extreme until it gets to the point where the heart really starts changing its hemodynamics. So the classic version of it, so constriction happens secondary to tuberculosis or tuberculous pericarditis, which is basically an infectious process that does that. So what do you know about tuberculosis at this point?
It's highly contagious disease, which can be the body. Usually it's spread in the lungs. It's very hard to treat, and usually nowadays it's resistant to antibiotics. So
yes.
Consumption.
Yes, and therefore, if it's resistant to antibiotics, the reason that they describe this as a classic presentation is because before the days of antibiotics, this was one of the main causes of constrictive pericarditis. And worldwide, in some regions, that still may be true. To Arena's point, we're now having a lot of drug-resistant strains of bacteria and stuff out there, and it is problematic. And if we do have drug-resistant strains of tuberculosis, which there are some out there, we may start to see a resurgence of that in the US again also. We still have other medications and stuff that they use, but it is very contagious. I know that we get very concerned about COVID, which, legitimately so, but comparatively, I would take COVID 1,000 times over taking even one instance of getting tuberculosis. It's significantly different in its effect on the patient. I've actually scanned in rooms, and this will happen to you at times. And this is why the universal precaution scenario is really important, is because you want to treat every patient as if they might have something very, very contagious like this. Okay, so you properly glove and gown, stuff like that. You're not, classically speaking, in the hospital pre-COVID days, you weren't always wearing a mask in the rooms. But nowadays, it may be less of a problem. But there's oftentimes I would be in scanning a patient, and then I'd walk out of the room, and it takes time to diagnose patients with disease processes. And if they're looking for these types of infections, they have to do clinical tests, they have to do lab tests, where they wait for results to get back. And it could be 2 or 3 hours, it could be a day or so before they get some of these results back. And I've walked out of rooms after scanning the patient for an hour, and they're posting signs with respiratory precautions. I'm like, what? And then you find out that they had like tuberculosis. You're like, oh my gosh. Um, so note to self as you're in, and I think this is one positive I think we can draw from the whole COVID experience is that expect the unexpected. When you're in a clinical setting, be very cautious at all times because you don't know what patient has what. Maybe when you walked in the room, it was fine, everything was normal. They had been undiagnosed at that point, and they found the diagnosis later. And then you're walking out later and you find out that, oh, they had this, or they had that, or they had HIV, or they had hepatitis B. Those things you don't know, and it's so the universal precaution thing, I'll just put a plug in for that. Very, very important. And take those things seriously because you just don't know when somebody has something that might be very contagious. One of the problems with COVID worldwide is not just with tuberculosis, but other things like malaria and things like that go through some of these other countries that are not quite as readily available on medications. Some of these disease processes are getting out of control now because of the shipping stifle that's happening because we can't ship between countries as freely as we used to. So now some of these disease processes are getting out of control in these other countries. And I know that because our dean, who is a PhD in infectious disease, he shared an article with us that showed that. And so, these are the ripple effects that happen when one small thing is changed. It can significantly affect what happens. So right now we're kind of in that flux. They're trying to figure it out. They're trying to get the shipments and medications where they need to be so that these types of things don't get out of control like they used to be. And hopefully we're not getting any further strains of drug resistance to these types of things. So long story short, tuberculosis, while it was classic, back in the day pre antibiotics, we might expect a resurgence of that. You might expect a resurgence of rheumatic disease as well coming back up because, again, bacterial resistance to medication is becoming a problem. So again, universal precautions, keep gloved, wear masks when you need to, look at the universal precautions as you go in the rooms. They'll have them posted on the doors, what you should have on, if you have to gown up, if you have to have respiratory coverage, etc. So nowadays with modern medicine, that's less of an issue, and it's more after disease, connective tissue disease, radiation therapy after years of cardiac surgery, things like that. So with, what do you recall about radiation? What does radiation do, and how would we get that on the heart?
Doesn't it cause calcifications on the heart or scarring on the heart?
Scarring, yes. Potentially, yes. It could go, later on to calcification, but yes, definitely the scarring. So like our valves, if we're talking about valve leaflets, remember the radiation, it's relative to the source of radiation. So the closer I am to the source, the more likely that structure is to be affected. So like an anterior mitral valve leaflet, for example, would be more affected than a posterior leaflet. Likewise, the right coronary cusp would be more affected than the non-coronary cusp, but they can both be affected. So what surface of the pericardium do you think may be most affected in a radiation therapy instance?
Oh, so the parietal?
Yeah, it would be it'd be the parietal and that fibrous cap for one, but what area of the pericardium do you think is affected most? Anterior wall or posterior wall?
Anterior.
Yeah, so the closer it is to the source, the anterior wall is going to be the one that's more likely to be affected, although it can affect the entire thing. So you can have sections of it that are more so than others. The stiffening of the parietal pericardium primarily may be involved compared to the visceral, but it can also involve the visceral layer. So the parietal layer, which sits against that fibrous pericardium, you got a bit of fluid. What's nice is that bit of fluid is actually a bit of a insulator, I suppose, towards the visceral layer and the epicardium, and underneath that you have your epicardial fat, which runs down the outside. I don't have the heart model in front of me, but sometimes you can even see that pericardial fat on the outside of the heart, and that's typically where our cardiac coronary vessels run. So the coronary vessels can be affected also, the myocardium, et cetera, et cetera. Now, again, if I'm looking at visceral and parietal layers posterior to the heart, they're going to be less likely affected than that anterior area is. So I think this diagram's a good the constrictor. It's a kind of cool design on a bus. That's pretty sweet. Good artist. But that's the idea, is it's kind of being squeezed from the outside. So remember that this is not a fundamental heart issue. This is a heart sac issue, or the space that surrounds the heart. The classic calcific form, where it is calcified, it forms a rigid shell. So we know that calcium is not very flexible. It doesn't, it's not elastic. It doesn't stretch. And it doesn't even bend very well. So if it gets calcific, it is a rigid shell. Again, Darren talks about the heart in the can type thing. Quite literally, where the calcification is going to be very hard. And that, again, what it's doing is it's limiting the space that the heart can expand and contract, because normally you have that expansion and contraction and the elasticity that's there. All right. So the elastic, which is more common, so it's not calcific, physical findings and pathologies are similar to tamponade. So there's going to be like the respiratory variation and stuff like that. So just because you see respiratory variation, don't jump to the conclusion that it's tamponade. So what other things does tamponade show us from what we've talked about? So think about the echo and what you get, what you need to show the doctor is proof. What are you going to show the doctor?
Go ahead.
Respiratory variations.
Yeah, respiratory variations in both mitral and tricuspid. Good. And what else do we want to see?
Just like the augment and flow with inspiration on the tricuspid side and vice versa for mitral valve.
Okay. Good.
Right ventricle collapse.
Yep.
And then the fluid.
The free wall collapse, that's a big one. Yep. IVC, some of this stuff's going to overlap a little bit. But again, you want to show that total picture of it. Just showing the respiratory variation may not be a diagnosis of tamponade. And as I suggested before, anytime that we get a low cardiac output, which is essentially what's happening here, we end up having a tachycardic heart trying to compensate for what's going on. So you'll also have the tachycardia. Good. All right, so in the echo diagnosis again, so we want to take multiple clinical, anatomic, and physiologic observations as a combined set to be able to determine and diagnose what this disease process is. So remember that it's not only echo alone, sometimes it's the other stuff that's telling us the story. Thickening can only be appreciated on an echo when we have pleural and pericardial effusion. Okay, so in other words, if we've only got pericardial effusion, we can't really see the thickness of that wall. We do see it better when there's fluid on either side of that wall. So they'd have to have a pretty decent sized pleural effusion as well as a pericardial effusion. And just from an anatomical standpoint and proving which one's which, what is our landmark again to be able to show the difference between pericardial and pleural effusion?
The descending aorta.
Descending thoracic aorta. So again, if it goes up on top of it between the coronary sinus and the aorta, then it's cardiac source, pericardial. And if it's beyond that and goes behind the aorta, it's likely to be pleural. And what did I suggest you should do if you think there is pleural effusion?
Scan them from flank on their flank on their back.
Yep. So down at the sides, posterior aspect of the sides go down and sagittal where the lungs and the diaphragm meet. That is the dependent portion, and that's where the fluid will collect. You'll see like a little tongue. It looks like a tongue of fluid that goes out into a, kind of triangular shape and floating in the fluid, and that's what you would see if that's the case. Now, again, if you're seeing it at the heart level, again, that's going to be probably quite a large pleural effusion, especially if they're laying on their left side. Okay. So the gradual dampening of the M mode beam through that posterior wall, looking again at the brightness or the intensity of that pericardial display is going to help to diagnose the pericarditis and that thickening. If it's calcified, it may shadow. So normally speaking, we get a really bright, strong reflector, which tends to reverberate a lot. So it's very easy to overgain this. That's why the dampening is the method we use. But you still may not see beyond that if we have a calcified pericardium. It may actually shadow quite a bit. And if we're talking about the current ones that are calcified because of radiation therapy, how well do you think it's going to be to see any of your heart views? Nada, right? If it's calcified and shadowing from the very first surface we meet, good luck finding the rest of the stuff you need to see. Now, typically it may not, do it as a one big globular calcification. It may be, calcific particles within it. So you may have shadowy streaks throughout your image that may be caused from that. And that's, again, a good thing to note, because as we're doing our physics and you're trying to figure out what artifacts are there, you want to go up and see where that artifactual display comes from. Is it coming right from the surface of the transducer, or is it coming from deeper in the structure? Can you see a rib that's causing the shadow, or is it just on top of the heart where the shadow starts? Those are going to be clues as to where those things are happening. Okay, and then the fluid space may be filled with vague echo-dense substances, which represent thickening of pericardium and inflammatory process. And again, as we get into those inflammatory processes and the metastatic disease processes, you're going to start to get that stranding and stuff that comes, sort of little strips of tissue peeling off the pericardial layer. And of course, as we've talked about before, the CAT scan and MRI are better than us at characterizing the actual thickness of it. And if we're looking at calcifications, CT and chest X-ray are what we want to see, because those hard calcifications can interrupt some of the MRI signals as well. CT and chest X-ray see the calcifications better. In fact, you'll see screening exams of the heart. I think with our 136 class, we can discuss this on the cardiac CT. There's cardiac screening that they do that's a calcium score they give. And what they're doing is they're actually scanning the heart and looking for calcification deposits around the heart, particularly where the coronary arteries are, to look for plaque buildup that's calcified. Now, doing that screening exam, do you think if it's not calcified, how well do you think CT sees that? If they're doing a calcium score, okay, it doesn't mean there's not disease process there, because we can have soft plaques that don't have calcifications. And if they've got a bunch of calcifications, does that mean we have significant stenosis? Not necessarily. They may have calcifications, which is bad, but they could be small constricting plaques that are not super constrictive. So the fact is, it just shows that there are calcifications there. That means that there likely is plaque there, but we don't know the extent of it. So if they really wanted to find out how much it is, they would need to do a stress test or an angiogram. Okay. So Doppler shows the only signs of constriction with regard to the hemodynamics. And if Doppler shows that as the only thing that shows it, then a cath, an angiogram would be indicated for that. Abrupt relaxation of the posterior wall with flattening, just like before we talked about. The septum, you might see early diastolic notching. I'm going to show what that looks like here in a second, followed by paradoxical and then normal motion of the IVS. Let's take a look at the picture. There's kind of your notching on there. You're also seeing, in this case here, you're noticing a difference, and again, likely this is respiratory variation, where the septal wall is dipping in during various parts of the respiratory cycle. Again, that's indicating if it's dipping in here, that's indicating you've got an elevated pressure at that timing of the right side. So again, with the constrictive, it's respiratory variation. And then when we do our spectral Dopplers, we're going to expect to see those E-wave variations fairly significantly. Okay, elastic. So that's where you'll see some respiratory dependency. So that's again suggesting that the calcifics type doesn't have any expansion contraction. So you're going to have less respiratory variation in that than you would the elastic type. It's going to, as far as the free wall and the septum goes, you're not going to see as much movement with the constrictive calcific. And then finally, the IVC dilation. dilation and lack of respiratory variation of the IVC diameter. So again, suggesting that the pressure in the IVC, remember it's trying to drain out from the lower part of the body. It drains directly into the right atria and it's coming up against resistance, which causes that to back up. So that's usually an indication that we have pressure back up pretty significantly and we're greater than 2 centimeters and the respiratory variation sniff test is going to be less. Nancy?
Can you help me find where it talks about elastic in the book?
Yeah. Look. This is right here, hold on. Which chapter is new? 10?
9.
Let's see. here. Echo diagnosis. There should be an echo diagnosis segment there where it mentions this. That's roughly page 229, goes on for a couple of pages.
Yeah, I'm there.
Yep. Anybody notice the inordinate amounts of pollen this year? Major hay
Yes.
fever. Major hay fever season. Makes it more fun with the COVID diagnosis. Okay.
So there's not elastic in the book. Is that what you're telling me?
Oh no, I didn't read through the. I'd have to look. It's in that section because that's the slide that I have it on. Is the echocardiographic diagnosis on page 229. It's that segment that I would have found that statement about the elastic. Just perusing through it here real quick.
Page 230 does talk about the septal movement.
Yeah.
It doesn't say anything about being elastic though.
Yeah, like when I search the online version, the only elastic words show up in there's only 9 words of elastic and it's in chapter 2 of physics and then evaluation of diastolic function. So
And so you have the PDF search version. I like that. I don't have that on the hard copy.
yeah, so I was confused because this isn't the first time today that I've seen that word elastic versus whatever. And so I was
Yeah.
confused about what it meant.
So what it means is it's not the calcific version of it. So the calcific is non-stretchable, non-elastic. So they're talking about without calcification, the constriction can be just a. It's more. It's still rigid, but it's not. It's more elastic than what the calcific version is. That's what it means.
Yeah, I can see you as you're trying to explain because the word elastic doesn't really mean rigid.
Right. So it's scarred, yes, but it's not. It's not normal elastic. It's but it's more elastic than. It's like a strain imaging. It's all relative to what you're looking at. But yeah, if it's calcific, it doesn't stretch at all. Whereas if it's not calcific, then there still is some give to it, but not as much as normal. They probably took
Sorry
that
to derail.
So when Feigenbaum retired too, by the way, so this book you'll notice is Armstrong and Ryan, even though it's Feigenbaum's echocardiography. So those were 2 of his colleagues that took over that textbook when he retired. So version 8, is this 8? Yeah, this is 8th edition. So 7th and 8th edition were actually written or continued by his colleagues. So they made some modifications to some of the stuff. Okay. I told you that Dr. Feigenbaum was the father of echocardiography and that he actually trained the very first echo tech. That's a little history.
Is it in United States or where is that?
Worldwide. He started it. So he told us a story personally in an educators meeting that we were at in Phoenix, and he couldn't find a tech. He looked for x-ray techs and other people to see if they would cross-train and start to do this new ultrasound thing. And he, as a doctor, of course, was doing some stuff with it. And he ended up finding this guy that was a janitor, who was just a hardworking janitor, just kind of really wanted to change his life and stuff. And he gave him a chance, and he worked with him. And he even told us that. So he trained him to be the very first echo tech. He trained him later. He actually wrote a reference for him to get into medical school because he had no education. And he worked him through it, and he even wrote him a personal letter of reference to get into medical school. He ended up not getting into medical school, but I think he ended up becoming an optometrist or something. But this guy that was just a custodian that didn't have any hope for himself in life, Dr. Feigenbaum found him and kind of trained him up and mentored him, and he became the first echo tech. So it's kind of cool. So that's why he's known as the father of echocardiography. All right. So again, just going through, we've already touched on a lot of this. So this is the findings in constriction. So we're going to look for that exaggerated EA, as we've discussed already, with the shortened deceleration time and exaggerated respiratory variation. Those are sort of our classics. Respiratory variation of E wave reliably defines between constriction and restriction. Okay, seen with, again, quiet respiration. So the patient's not taking deep breaths in and out. We have our deep breathers, but just a quiet respiration is just normal, semi-shallow type of breathing. So you're gonna, not have the patient hold their breath. You want them to breathe to be able to get these waveforms. So you may have to kind of follow with your transducer as the heart beats and they move a little bit. We already know that the image comes and goes as the patient breathes. The trick is you got to kind of follow it. So one of the tricks that I learned for myself over the years was, as I'm scanning that type of thing that's moving, we've got our rib spaces. It would be like my bones in my hand here. And say I've got my really good window, but the heart is moving up and down within that space, and so it's coming in and out of my Doppler. So what I do is I kind of, you get to know where the heart is going. And so as the respiration is changing, I'm slightly moving with the mitral valve to be able to stay on the Doppler. And on your Doppler signal, you can tell based on the quality of your signal, if I've got very sharp borders to my waveforms, I know I'm on it. But as I start to get kind of ratty borders and it starts to lose that detail, I know that I'm not falling in and out of it, but the heart may be coming in and out of my Doppler sample. So you'll get to learn how to kind of, with respiration, with the heartbeat even, you're going to move your transducer a little bit with the Doppler to be able to stay on it. It's kind of the next level kind of technique that you'll learn how to do to be able to keep your good quality window, because they do come and go. You've all seen with the tricuspid jets how hard it is to get a full envelope on that jet with a small tricuspid regurgitation, because the hole is super tiny and my Doppler is not all that big, and it has to be aligned. And if it's falling in and out of that, we're only getting part of that envelope, which is why we see it that way. Sorry, I don't know what I just did there. There we go. Read super tiny slide. Okay, and again, the variation, according to Feigenbaum and by my testing standards, I'm going to go by the 25% variation or more is going to be diagnostic of this. Same with the tamponade, more than that variation. I know that the ASC book suggested 30, so 25 to 30, if it's there or above that, I think would be reasonable for registry type of stuff. Again, from a screening type of an echo where you're maybe not like the end of the line echo, I would set my threshold probably at 25 to start calling it, and then give that to the doctor. And maybe they're more comfortable to say, no, I'm going to go with 30, but I'm going to give 25 as a harder baseline so that I catch more patients that are real in that situation. The risk of waiting till it's 30 is that maybe something changes, your patient sends the patient away and it becomes worse, and something happens before they can get back to medical care. So I'm personally going to probably have my threshold at about 25. Okay, so if the classic findings with all that E-wave exaggeration and all the stuff that we've talked about, if we suspect that there is something there, but we're not really seeing it, we want to repeat the Dopplers after doing volume loading. If the volume is depleted, maybe we need to IV therapy them and get that overall volume back up. And then we can also do a head up tilt, okay? And that may unmask the findings. So that head up tilt may change the volume such and the pressures that we just enough to be able to reveal what's going on. It's sort of like doing a Valsalva maneuver does. We're doing a technique to kind of temporarily change what's going on. And remember that patient position can make a difference on what you see in these types of things. All right, some Dopplers, just showing again those inspiratory versus expiratory stuff. I'm just looking at the lines. I pulled this right out of Feigenbaum, but they must be measuring some wispy stuff here. And this is the actual lowest one here, and that's the highest one. It doesn't, I don't think I would measure it quite that way, but there might be some detail lost in the picture too from the time it was taken on the ultrasound machine and actually sent in. But that's a difference a gaining can make as well. Okay, note that we have hepatic veins and stuff on here as well. So we're going to be Doppler sampling other things too to help confirm diagnosis overall. And this is also going to help us to differentiate between constrictive and restrictive. Okay. All right, so in the Doppler hepatic veins, of the hepatic veins, we're going to look at the diastolic flow reversal. So in expiration, there's going to be an increase in diastolic flow reversal. And this is again hepatic veins. So they talk about flow reversal, meaning going away from the transducer. It's not that it changed direction like it would on a severe TR. This is just that it's increased velocity. It's still going downward as it usually does, but it's just bigger than usual during expiration. And then the elastic forms of it, non-calcified, in other words, systolic antegrade is increased during inspiration. So you'll notice that there is going to be a change in respiratory variation on those hepatic veins also. Having said that, this is going to be kind of it is direct evidence, so it's kind of a primary piece of information. It's just not necessarily our most important information. I'm definitely doing more of the Doppler on the mitral valve inflow and the tricuspid valve inflow. Yeah, Nancy?
Why would they take that last bullet point out of the book?
Maybe they're not using it anymore. That could be. Maybe they thought it wasn't quite as relevant. And as I suggested, that's not going to be something I'm going to hang my hat on. This is going to be an extra piece of information. So sometimes bringing back some of the old school stuff isn't a bad thing if you're kind of trying to split hairs and see if there's enough evidence to call it one way or another. You can know that going back and doing one of those old school type of measurements is might show us something. Yeah, why they took it out, I'm not exactly sure. Even the EKG, when I did the EKG book the first year, the version that I had some videos and stuff in it, and actually had like Wolf Parkinson White and stuff in it, where the latest version of the book didn't have it. And I actually kept that information because I think it is useful, particularly for students who are going to take a registry exam. You kind of want to have that in your toolbox. Okay, so effusive constrictive pericarditis. So we're talking here now just about the effusion state with constrictive. So we do want to differentiate between constrictive and tamponade. So that's going to be important. Remember that tamponade is emergent. Constrictive isn't necessarily emergent, but it is something we're going to want to deal with. It can happen in malignancy and radiation therapy. So again, radiation therapy, because of the malignancy, is going to scar up that layer and in this country is going to cause more of that presentation than we'll see otherwise. Again, if you're in a third world country, say for example, you get with one of the cardiology groups in town here that likes to go to Rwanda every year, you might see more of that from tuberculosis cause than you would radiation therapy from cancer. Thickening of the visceral pericardium may prevent RV or right atrial free wall collapse. Okay. So clinical diagnosis will be made in the patients with hemodynamic compromise. So what does hemodynamic compromise mean again? I think that term's important to kind of understand what it's talking about.
Just basically saying there's like not enough output, not enough blood flow.
Yeah, so it's actually changing the blood flow dynamics is what's happening. So that's our EA ratio changes. That's the stuff we're seeing on the hepatic veins, etc. Those are hemodynamic changes. So in this particular scenario with having hemodynamic compromise and a moderate pericardial effusion, they also sometimes have jugular vein distension. So you've seen it when people are talking a lot and they're arguing or mad at you, and you can see their jugular veins kind of pop out of their neck, you know, and then they start breathing and it goes down. That won't go down with the breathing. It's persistently protruding out, and so those are signs. It's signs of other stuff as well, but they might have jugular vein distension, and the hemodynamics still persist after pericardiocentesis. And again, at pericardiocentesis is when they actually drain the fluid off, and we'll talk about that at the end of this slide set. So those hemodynamics, they persist. After pericardiocentesis, the effusive component resolves and hemodynamic constriction becomes more obvious. Okay, so constrictive versus restrictive, and there's a table that I have in here in a couple of slides that kind of lays them out side by side or on the same table so you can see the differences. So again, just like EKG, you want to kind of draw out the differentiating things because some things will be the same for both of them in the presentation overall, but I want to differentiate between constrictive and restrictive. So I want to find those things that are different. One of these things does not look like the other. All right, so more common, it's going to be differentiating between an idiopathic restrictive cardiomyopathy and occult constrictive pericarditis, not meaning it's satanic. Doesn't mean that. But, you know, constrictive pericarditis. So the biatrial size is going to be one of our important differentiators. So the restrictive cardiomyopathy is going to have large biatrial sizes. So we talked about that with restrictive. Constrictive is going to be relatively normal size. Okay, so if you're looking at the difference, remember those pictures that we saw where those biatrial were both, you know, at least double the size of the ventricles. They were quite large. Plus, you're going to notice your Doppler signals and stuff like that, those super high E waves and A waves and stuff like that. Kelsey, go ahead.
Why is that? Is it just because the heart in a can is affecting the chamber to dilate, or?
So if I was to have this super long term, I would expect that those chambers might get bigger. So in a more chronic version of constrictive, I would expect that eventually it would back up. But it's mostly backing up because the atria are still contained in that space. And if that space is constricted, it's not going to allow for expansion for one. So it's going to back up the fluid into wherever it came from, the IVC, SVC, pulmonary veins, whereas the restrictive doesn't have that constriction and they expand pretty significantly. So one of it's the restrictive nature of that. And then restrictive is typically a long-term chronic type of a development where those atria expand pretty significantly over time. A lot of this constrictive stuff is more acute than that, even though it did suggest at the beginning that some of this is a longer-term process. Just remember that if it's longer-term process, I expect the atria to be bigger than if it was short-term. If it's a short-term thing, like I get a sudden change, like an infection from tuberculosis, for example, it scars out probably over a year or two. It's not going to allow that much expansion, and it's that space around it from the sac is restricting its ability to be able to stretch out like it would in restricted. Does that help?
Yeah, that's what I was thinking. So
Good. So biatrial sides, that's a big one. The next one is the respiratory variation. So in constrictive, we get that greater than 25 or 30% different during inspiration, expiration of the peak velocities of the E waves. So constrictive will have that, the restrictive does not. And then you could go to the hepatic veins and the SVC. Constrictive there will have a systolic antegrade flow, increased flow with inspiration. Restrictive, there's less variation, and the diastolic flow typically exceeds the systolic flow, or the D wave is usually bigger than the S wave. Again, that's going to be, you may not go to that in some labs. Some labs may want you to do it, some labs may not. Tissue Doppler is a big one. So in constrictive physiology, remember, it's not the function of the heart that's the problem. It's the constriction of the sac around the heart that's the problem. So the muscle and the tissue moves pretty well, relatively speaking, to restrictive, whereas restrictive has very low velocities because we have very stiff muscle tissue because of the fundamental muscle tissue. And DTI is more valuable than, again, the hepatic veins or the SVC flow. So again, a lot of labs, and they may be even taken out of the textbook because those other parameters are just better. If we were to look at propagation velocity for the labs that do that, so again, color Doppler with the M mode run through it in apical perspective from the mitral valve towards the apex. Normal for that propagation velocity slope is greater than 55 centimeters per second. Constrictive is normally exaggerated or longer, whereas restrictive physiology is pathologically reduced or shorter. So it'll be less than 55. And here's that table I was telling you about. So you just kind of run through that stuff and pick out the major ones, which we just talked about on the previous slide. All right, so postoperative effusion. So after surgery, it's not uncommon to see effusions. Okay, so we get them fairly commonly after surgery. We don't want to see big effusions, and over time they will start to dissipate and become reabsorbed. It could be difficult though to scan because, again, if they've gone through open heart surgery, how easy do you think it's going to be to see your parasternal views? Because they crack the chest open, they've got bandaging all over the place and tape that expands beyond that space. So it may be difficult to see just from getting an echo image perspective. You can often see some hemorrhagic or hematomas. So again, the hematoma is a coagulated blood clot basically inside. It's not a blood clot like a vein, but it's a collection of coagulated blood inside that pericardial space. That's what a hematoma is. Oma typically refers to a mass. Okay, so it's basically a collected blood mass. And hemorrhagic means that it's actively bleeding. So those can be because of that. If that's what we see, anything that we see that's abnormal, you want to document its appearance. You want to document its size, including measurements in 3 dimensions, three orthogonal dimensions. And often you want to put color flow on it if it's not something that's moving around a ton, to see if it's got its own blood supply. Because if I saw like a big mass in that pericardial space, it's kind of pressing in on the heart, likely it's a bleed. But what if that mass or tumor has a blood supply of its own? In other words, arteries going into it, that's a cancer, okay? And just like we talked about renal cell carcinoma versus an IVC thrombus that comes up into the heart, seeing blood flow inside of it is a pretty ominous sign of a cancer. And again, always evaluate the size and shape, look for blood flow, look for anything else that it's affecting, look at what it's pressing in on. Things with more defined borders are usually more benign types of things, and things with borders that you can't really see very well. That's what we call an infiltrative type of a mass. And again, we're going to get to masses and tumors later, but those types are more likely to be cancerous or desmoplastic, is what they call it. We'll evaluate pulmonary veins, SVC, and IVC. These types of things can also result in a compression. So again, as I suggested, if we got that bleed or something that happens in that pericardial sac, that's taking up space inside the pericardium that's affecting how the heart can beat. So you might, on like an atria, if it's close to the atria, you might see a mass effect where it's actually pressing in on the wall, not allowing it to kind of stretch out like it normally does. It's less likely to have an effect on a ventricle muscle. Okay, so echo-guided pericardiocentesis. So echo-guided, suggesting that we are using echo to direct them into the pocket of fluid. That is true, and that happens very commonly now. Old school, before echo was around, they used to kind of tap on the rib spaces, find that hollow sound, and they would tap it in, and they would draw back the needle and see if they got fluid or blood or nothing, and adjust it. And you know, when they start to see the fluid that they thought they were supposed to see, they would continue to draw it off. Thank heavens for ultrasound. It's not horrible that they do that, but you can cause more damage by poking needles randomly through stuff, right? So what we do as an echotech for this is we're going to find the pocket of fluid, and we're going to see where the biggest, deepest pocket of fluid is, because that's where they want to approach it and stick the needle into. We want to try to stay away from the heart if we can. So we have to measure the depth of that pocket of fluid, the depth it is from the skin surface to the top of that, so they know how far to push the needle in. Yeah, Kelsey?
Well, I know that everything's in the dependent position. So are they on their side, like left lateral then?
They can be. It depends. They may have them sitting up on a bed, not sitting up necessarily, but they may prop the head of the bed up significantly and do it that way. They may have them standing. We used to do thoracentesis, which is the draining off the pleural effusions. And what we did there is we have one of those food tables that they have in each of the rooms. We'd have the patient put a pillow on there, and we'd have the patient leaning forward so that they could access it from the back. Obviously, they can't do that with the heart. I think that they would like it. I've never personally done one of these, but because I worked in a clinic, not a hospital, I would probably prop the head of the bed up. That would allow the fluid to settle down near the apex, because they'd rather go in by the apex than up by the vasculature and stuff that comes in and out of the heart. So they want to drop it down, so probably sitting up. They may come kind of just in the front there, in the mediastinum, and drain it from there. I've never personally seen it done, but and we got a couple of pictures. So they might be semi laying down, semi head propped up somewhat. Because yes, it will go to the dependent portion.
Yeah, because I was looking at, like, I have the slides where you print it out 4 at a time, and I was looking at the next slide, and it looks like these patients are like laying down in the schematic here, so I wasn't sure.
Right. Yeah, I would say at least slightly head up. That would make sense. So we'll document that. When we're doing a procedure, you'll usually take a clip of it, and what you want to do in the procedure is you want to show where the needle tip is. For legal documentation, we need to show where the tip got to in case something happens bad, that we can say, you know, we want to confirm that it's actually in the fluid, because if it doesn't get into the fluid, you're not going to draw any fluid out. And if you go too far, you're going to poke into the heart, which is bad. So we want to show where the needle actually was. Now, I don't think this slide set talks about it much, but what was when you did the IV therapy, what was that needle like? How did you do the IV therapy? When you stick it in, it's got the needle inside it, right? So you got to have enough to poke through the skin, and then it has the sheath around it, right? So the catheter sheath. And so that's what this is. That's that type of thing, but it pokes right into that fluid space. Then they pull the needle out once we confirm that it's actually in the fluid space. And we try drawing some fluid back. They pull the needle out. They'll have like a stopcock or something on it. They'll put a tubing on it, and then that gets drained out. So we like to drain by gravity if you can. but they can also do vacuum suction. So vacuum suction, they can actually get these bottles that are pre-vacuumed. So just like your fruit jars and stuff, when you go and open a new jar of peaches or something off the shelf, and you crack it open, you can see the suction comes back out, right? So these are pre-suctioned empty vials or bottles that have a tube in it, and that's what we connect to it, and that can actually suck that out. Or we can put suction on the wall of the hospital. You'll see these little containers that hang on the wall by where you have your oxygen connections and things like that. And it just screws on and off. And that has a hospital vacuum that will suck that out as well. Gravity is usually better because then the body's sort of doing it on its own, but you may need to suction it out to get that extra fluid out.
We get those bottles at the lab and they're so gross.
They're pretty nasty. Yeah, and they're clear, so you get to see the and some of the comments when you put your lab samples and stuff in, you actually describe what the fluid looks like. Is it straw colored? Is it clear? Is it red? Has it got blood in it? You know, stuff like that. So we do want to remove it, and as I suggested before, particularly if they're concerned about cancers, they're actually going to send it to the lab and test the fluid to see what type of pathology is causing it. So don't be surprised to put labels and stuff on and send it to lab. Agitated saline can be injected into the space to identify the tip of the needle as well. So if you don't think you're in the space properly, you might put a little bit of agitated saline into that space. And if you're seeing bubbles floating around, you know you're in a good pocket, and then you can start draining it. You don't always have to do that, but that's a method to try if you can't see it super well. Afterward, you'll use 2D to evaluate the fluid, the pocket fluid after that. So just a note on measurements, we often try to measure the size of the pocket of fluid around the heart also. So in radiology, when we're doing like a thoracentesis, we'll actually measure in 3 dimensions the size of the pocket so that we can measure it after and compare how much we drained off. I don't personally know if they do that in cardiac because the fluid goes all around the heart. So they may not quite do that the same way, but it's good to document roughly the size of the pocket that you're draining out. And you can do that by a simple caliper in the space to see how much that takes up. Okay, so acute right heart dilation can be seen after large volume removals. So as I suggested a couple of days ago, if we did like a thoracentesis and say we did an ascites removal off the patient. Remember I told you we got like 17 liters off that guy, and you know, taking like 11 liters is sort of the limit, because if we take too much off, now you got all this backed up fluid pressure out inside the abdomen and stuff that's now rushing forward into the heart. If we take it off too much too quickly, it can cause right heart failure and right heart dilation. That's what this is talking about. And they may show mild signs of right heart failure if we do draw it off too fast, because now we're doing an acute volume overload essentially. All right, so there's your pictures. That's a nice small needle, right? Anybody want that stuck in them? This is not your 25 gauge needle. This is probably more like a 14 gauge. This is like almost the catheter type stuff they use in the cath lab. I mean, big needles. And this is not the biggest thing that they stick into the body. When they do renal biopsies and that's about the biggest biopsy needles I've seen, liver and kidney biopsies. Big, thick ones. They've actually got centimeter markers on them. Yeah, it's got a very distinct sound as it goes in. I won't go into too much detail on that. But big needles. And this is a good technique to show. My wife, when she had the kidney stones and she was in the hospital, they had a hard time finding her IVs. So ultrasound guided IV sticks are really handy as well. But the nurse that was there, that was the pro that they brought in because nobody else could get it. They brought him in with the ultrasound machine, and I'm trying to be quiet in the side of the room and not say anything, and like watching him do this, and he's doing it in transverse, and he's trying to get in, and he's trying to see the needle, and you just can't see it. You want to track it in long axis. So what this person's doing is they've got it that way, and your needle should go along the beam. It should go within your sector to see that. The transverse thing just got me going. Kelsey?
Okay, it might just be because I'm interpreting the picture wrong, but in this situation, it looks like maybe it's the doctor holding the transducer and the needle.
Yes.
So-
You could have a tech hold it. You need to be sterile technique, so you need to put on sterile gloves, and in the pro covers you can see it's sterile. They use like a betadine or an iodine solution to clean the skin. That would have been a sterile needle and all that stuff, so it's all set up sterile. He's not necessarily wearing gowns and all that kind of stuff. The patient doesn't necessarily have to have sterile towels over them like in a surgery. But we clean the space. They do have to be sterile. The tech is likely operating the system. So they're taking pictures of the video clips and stuff of the needle where it's placed and stuff like that, so you can document it. And afterwards to document how much fluid is drained off, and to re-obtain the hemodynamic waveforms to see how that's changed, because we would expect to see a change. Yeah, go ahead.
So when we find the dependent portion of it first, we're scanning first and then they go sterile up and everything.
Typically, yes. So common technique, and when we do like thoracentesis and that, so you'll do this, you'll sterilize, you can scan without being sterile first. So you can use regular gel and all that stuff. We're going to clean that up, then we're going to sterilize the environment. Actually, the doctor is going to sterilize it, because you're going to have the tray out for them. They'll have like a betadine little sponge thing with a handle that's got stuff in it. And they'll scrub it on. They have to do it in a certain pattern, and you learn that stuff with Tina, I'm sure. You set that out on the table for them, and then they will grab the stuff as they need it. So you might need to still open stuff, but typically we open what we need to right away. Often they come in kits. So we get like a thoracentesis. It's a big boxy type of tray, like almost like a utensil tray that goes in your drawer. And you basically peel off the whole top, and everything's right there, already ready to go. Otherwise, you're going to need to take individual needles, open them up individually in a sterile technique, and put them on the tray for the doctor. Sometimes the doctor will have the tech scan and they stick the needle. The tech will not stick the needle. But oftentimes, and it's actually easier. And if it was me scanning it as a doctor, I would much rather have control of the transducer myself while I'm poking the needle in. But some of them don't have that scanning technique, so they may do that instead. As you can see, this is clearly not a cardiac transducer either. This is a curvilinear. This would be a better option to stick a needle in to see it than a phased array transducer would be. So just FYI, you might be using a different transducer, but if that's all you got, that's all you got. But a sagittal perspective is the best way, because you can track and see the needle as it goes in. You can see where the tip of the needle is. Many of these needles actually have substances like crushed glass in the very tip of it, so that you can see it really well on ultrasound. Otherwise, it can be tough to see the tip. So there sometimes are special needles to be able to be seen well on ultrasound. So they'll stick it in, they'll drain it out. You can see the different approaches that you can see, and you're just going to find the best pocket, stick it in that pocket. We want to make sure we're not passing through something else that's going to damage something. And then the drainage tube, particularly if it's gravity feed, you'll have the tube goes down from the patient so that it sucks it out. If you have the bag of fluid higher than the patient, it's not going to drain. In fact, it may actually fill back into the pericardium, which you don't want to happen. So when we do our initial scan, we may find a spot. You can get special markers that are sterile. Not even sterile, you can use like a Sharpie, but there's medical grade Sharpies. They'll make a mark on the patient's skin where where we think the best pocket is. When the doctor scans and before they do the biopsy, they will scan over that spot and see if there's any other spots that they want to do it on. And then that's when they'll go and tap into where it is. Another technique is if you don't have a Sharpie, you can use a straw. And this is before they sterilize the field. You'll take a straw and press in on the skin. You've all seen if you press in on the skin with something, it leaves kind of a little mark there for a few minutes. So it will leave a little circle where you press the straw in on the patient, and that's kind of their locator as far as where they need to go and try to tap into it. It's kind of interesting. Yeah. Okay, so Beyond this, then just continuing generally speaking with the pericardium, I alluded to the fact that you can have kids that are born without even with the heart outside the chest wall and stuff like that, or that they might not have a pericardium. So it may be partial or it may be complete. So meaning that there's no pericardium or some pericardium and not all the way around the heart. Often these patients are asymptomatic. Obviously, if it's outside of the chest, that's a bigger deal. The left atrial appendage, so if we have a partial, just like a hernia, if the left atrial appendage or right atrial appendage gets caught out in that, it can strangulate itself and cause some complications with that. So the danger with the partial ones is that it might get like a herniation type thing that's happening and strangulate that tissue. Maybe in an abnormal position due to a lack of constraint. So in other words, the heart is not necessarily going to be how we expect to see it normally because the pericardium normally holds it in place. So it might be more mobile as far as where it ends up in the chest. Abnormal and frequent paradoxical ventricular septal motion has also been reported on this case. And then the last thing on pericardial disease, the body is weird. It develops cysts and weird things all over the place. We'll get into masses and tumors again later, but pericardial cysts can happen. They're typically benign, meaning that they don't spread. They're just there. They're typically fluid collections. They have usually a fairly thin wall to them, but they don't really do anything or harm anything. They're just kind of there. They occur near the costophrenic angle. And so I put a picture of chest x-ray on there just showing you what costophrenic angles are. So costo has to do with the cartilage and the ribs, and phrenic has to do with the diaphragm. So where the diaphragm meets the ribs essentially is your costophrenic angle. So that's usually where they're found, or they can be found there. They're most commonly found near the right atria. They, like any type of thing, like we talked about hematomas, how they can press in and have a mass effect on the heart, so can a cyst. The cyst is there, it's usually filled with fluid and it's usually pretty stiff. And if it's near a right atria, for example, it might be pressing in on that right atria. They're diagnosed better with CT and MRI. And if you needed to, you can use contrast and color to exclude any other anomalies. So again, color Doppler on a mass is always a good thing that if it's a mass you're not familiar with, because if it has blood supply going into it, like an artery, that's usually a pretty bad sign. And it's usually a sign of a cancer. And so any mass, take 3 dimensions, document where it is, what it's next to, what it's affecting, stick some Doppler on it. As far as color Doppler, you don't necessarily need spectral Doppler or anything, but documenting size, shape, boundaries, what's in it, that type of stuff is what we want to do. And that is pericardial disease. Any questions about that? I'm going to get out of the slide here for a second while you're thinking.
I have a question.
Yeah, go ahead.
So how does that septal motion, how is it not affected in restriction and like versus constriction?
So constriction, remember, it's going to be favoring right or left side depending on the pressure changes. And remember, with constriction, we're getting alternating, a significantly alternating pressure on the right and left side. So it's going to be pressing in. So if you slow your sweep speed down, you'll see the septum going along its normal contractions, but then it will dip, and then it will go back up, and then it will dip. Restriction is not going to do that. Okay, so what I'm looking up is pericardial sac. So I want to kind of go into some pictures here real quick, because I want you to be familiar with what the sac kind of looks like. So these are obviously like pictures of around the heart. We get that. What I want to see is a cutaway like this. So this is an anterior perspective on a cadaver type. This is a diagram, but it's a cadaver type. They cut the heart out. You can see pulmonary veins back here. You can see aorta and vessels up top here. And this is the heart taken out. And so this is the space behind it. So you can imagine the pericardial sac going all the way around. You can see in here where the pulmonary veins are, the sac does go a little bit into there. There's little pockets that go into there. But you can also see this doesn't, let's see if I can zoom up on this. It'll let me somewhat. Let me see if I can click right on it. So there's a couple sinuses that sit back there. And you can actually see these sinuses sometimes on echoes, on the regular echoes. Where's this picture coming from? Heart, looks like a dissection of the heart. Yeah, there it is. So we have an oblique sinus and a transverse sinus that fill those spaces. I can find a different one that labels it. Probably a better one. So this is the transverse sinus. So the transverse sinus sits just above the space where the upper pulmonary veins are, and there's a little space that kind of goes around here, and that's going to go behind the aorta. So sometimes we can see that. And we also have this oblique sinus, which is basically a pocket that forms inside, in between basically the four pulmonary veins behind it. Otherwise, the sac is completely open. So I just wanted you to be aware of those sinuses. So the oblique sinus, again, sits between the pulmonary veins behind it, and the transverse sinus kind of goes on top. I know that the guys from Duke would like to try to trick my students every once in a while. They'd show like a parasternal long axis with a little triangular pocket behind it. And they're like, what's that? And you're like, I don't know, transverse sinus. If it sits behind the aorta and between that space in there. That's all I wanted to show you.
We're talking about sinuses for pericardial fluid, correct?
Correct. Yes, this is in the pericardial space.
Do you have an echo image of that? I like Duke would try to trick us on.
Let's take a look. Let's see. Let's go transverse. See if we can find a picture. Okay, where the asterisk is. So this is kind of this is a long axis view. You can see there's a little tiny pocket of fluid between the aorta and the LA. So that's the long axis. This is short axis. You see this little triangular shape right there, there, and there. That makes sense? So if they point to this random pocket of fluid and there's not like an abscess or something going on there, transverse sinus is your answer. Probably found it. I just want to get this here. So, so this is showing an oblique. Let me go into this. Let's go to this one. So if it, well, let's see, that's not, that's better. I'm not going to go that. This is a reflection of an oblique sinus right here. I don't like that image because it's going to suggest that it goes behind the aorta and it's actually plural. Just note that it's going to sit up higher here, and it kind of goes between there and the aorta. So I don't know if there's any good pictures of that. Just note that that sinus is there. And if somebody's trying to trick you, you can look super impressive by pointing that out. I like my students to get the right answers in clinical.
Kat, could you please clarify? I didn't get it. So if it's oblique sinus, it means there is some, it's a pathologic state, right? And if it's transverse, it's normal?
Not necessarily. If there's a bit of fluid in there, it's fine. Just note that it's there. If it's really big, then yes, it might be pathological. But if it's tiny and you just see a pocket of fluid or sliver of fluid behind the left atria, for example, where the pulmonary veins are, just that's a normal structure that's there. But if it's really big, then yes, it's abnormal. And same thing with the transverse. And that's all I got. All right. That sounds like a day. Sounds like a week. All right. You guys have a wonderful weekend then.
Thanks, Scott.
Thank you.
Thank you.
All right.